Everybody's there, right? So I'm going to introduce Dr. Copenhaver, and we'll start the presentation. So welcome everyone, and thank you for joining us. We hope that this information will provide you some information on handling pain, and also give you a perspective of what is being done to help provide services and help people who suffer continually from pain. Let me introduce Dr. David Copenhaver. He is the diplomat of the American Board of Anesthesiology. He is board certified in both anesthesiology and pain medicine, and he is the director of the Cancer Pain Management and Pain Telehealth program at UC Davis. He has received national recognition for his commitment and dedication to both cancer pain management and the endeavor to train primary care providers in fundamental principles of pain management. Dr. Copenhaver serves as the chief of the pain division for UC Davis Health and as an associate director for the Center for Advancing Pain Relief at the University of California, Davis. He is an associate professor and has faculty appointments in both the departments of anesthesiology and pain medicine, as well as neurological surgery. Dr. Copenhaver completed his internship in internal medicine at UCLA and then went on to train in the field of anesthesiology at Columbia University College of Physicians and Surgeons. As the director of the Cancer Pain Management and Supportive Care Service, Dr. Copenhaver utilizes neuromodulation in various novel strategies to improve the quality of life for those suffering throughout the continuum of the cancer pain experience. So welcome, Dr. Copenhaver, and I will turn the screen over to you.
No, thank you very much, Daryl. I appreciate the warm introduction, and this is a first for me. So this group, I'm thankful to be able to present. Well, with that kind of introduction, what I could tell you is that pain management has grown over a period of time, and I could tell you that, just to preface, if I had to, and I apologize for the few minutes of being late, but here I can try to summarize quickly in one part, and then we'll start with the presentation. When it comes to cancer in general, I was a caregiver, and I realized quickly, as we're all in this, in the ether together, in reality, is just people helping people, that we didn't have, in terms of, when I say we, the medical industrial complex wasn't as proficient at dealing with pain and its associated implications, particularly in the setting of cancer. And so as a caregiver, I realized and then focused and fashioned my career to go in this direction. What I would say is we're kind of victims of our own success now when it comes to dealing with cancer, and I'll give the implication of neuropathy because we're going to be talking about today chemotherapy induced neuropathy. And by victims of our own success, I mean, we're living longer. Cancer treatments are pretty good for many different types of cancer, but it doesn't, the chasm, or the quality chasm, is there. So our quantity of life is extended, but the quality of that life is still, let's put a gentle question mark. So today's conversation is going to be about chemotherapy-induced neuropathy, so severe pain in the hands and feet, largely. And when we have that type of pain, it's not necessarily divorced from diabetic neuropathy. It's not necessarily divorced from other types of nerve injury. And what we find with cancer is it's a good surrogate to understand a lot about neuropathy in general, because we have, in order to treat cancer, we actually end up offering surgery, radiation, or chemotherapy. So we haven't gotten too far away from cutting things, burning things, or pouring chemicals on things. And all of those very important roles of caring for folks also portend risks associated with quality of life later.
Yeah.
So I'm going to go ahead and share my screen here and see if you can see this in just a moment. We'll see if it pops up. Okay, I don't know. Can you see it, Daryl? We're good to go. Okay. We got the thumbs up. And here's kind of the title: Chemotherapy Induced Peripheral Neuropathy and Spinal Cord Stimulation. So what I am going to talk a little bit about is novel strategies, kind of what is the current strategy in treating neuropathic pain, peripheral neuropathy particularly, and then chemotherapy-induced neuropathy, and then what's some novel strategies. Um, uh, so you'll notice these models here. This is actually from a local Sacramento group in Sacramento that utilizes art to actually transform how they feel. And this was shards of glass in the feet, and really the kind of the profundity of what people feel when they have severe neuropathic pain, in this case in the feet. No disclosures to give. So I kind of believe in that quick, firm kind of thought back from the old TV days, right? Tell them what you're going to tell them, then tell them, and then tell them what you told them. Okay. So here's kind of what's on the menu quickly to digest for lunch today when we're talking about this. Epidemiology, chemotherapy-induced peripheral neuropathy. What's the global picture in terms of numbers? Pathophysiology, just briefly. Current treatment, and then neuromodulation, or a look to the future. We'll talk about neuromodulation as one strategy, which is this spinal cord stimulation. But what does it mean? What are we currently learning? And maybe even I'll give a plug to UC Davis and basic science and the researchers at UC Davis that are doing incredible work when it comes to developing new therapies for pain. So cancer still is a major concern, and it's a leading cause of mortality worldwide. Of course, I kind of mentioned earlier, we're kind of victims of our own success in the sense that we're living longer. The days of understanding even the most profound types of cancer, pancreatic cancer, which the mortality was substantial. Even now, with some chemotherapy-induced trials, we're living many months to even years longer with profound disease. That said, there are a number of implications associated with the treatment of cancer that can kind of limit people from getting more treatment. That is, if your pain is so severe because of the elements or chemotherapies we're using to actually treat your pain, you may not be able to get more chemo. You may want to say, doctor, I just don't want to get any more of that chemotherapy because it's problematic and it's certainly painful and I just can't proceed. And so that obviously limits treatment and mortality from a different perspective. So if we look at this, I kind of describe here that the ability to detect cancer and treat cancer allows for these growing ranks of cancer survivors. But when survivorship is so profound, right, where you're living longer, but you're living longer with sequela or injury from the treatments, whether they be radiation, chemo, or surgery, there is something called survivor guilt. And we end up seeing that where patients will say, God, I really feel guilty for saying this, but I wish cancer would have taken my life because I feel that my quality of life is so poor. So although thankful for quantity, we have a lot to do in terms of our work to meet quality. And that's kind of what this conversation is a little bit about. Not to take anything away from quantity of life. I think it's a wonderful thing. It's just how do we as Walt Whitman said, for those of you that are vegetarians, forgive me, but suck the marrow out of life. How do we get more quality? So chemotherapy-induced peripheral neuropathy prevalence 18 to 85% in those individuals. We have a number of different types of chemotherapies, from platinum-based drugs to taxanes, and then thalidomide. And you'll see the numbers there that pretty much all three larger categories are all responsible for some type of chemotherapy-induced neuropathy. You may remember that thalidomide is really that drug that had many years ago had prevalence with the idea of morning sickness, and it was used to treat morning sickness, but resulted in severe limb deformities in babies. And thalidomide has found a home as a chemotherapeutic agent, and we'll get into exactly some of the function of how it works and why it can cause chemotherapy-induced peripheral neuropathy injury. toxicity, either with single doses of chemotherapy or cumulative doses, and then of course um, uh, transient permanent pain states are also part of the panorama of chemotherapy-induced peripheral neuropathy, meaning injury, and then there's kind of a supposition where, don't worry, your body will recover, things will get better, give yourself the 6 months, 1 year. But yet there are individuals that do improve, but then there are scenarios where we have persistent uh, pain. So prevalence of this condition with neuropathy peripherally after chemo, about 68% of the individuals notice this pain with most types of chemotherapy in the first month. Now, I'm not talking largely of biologics. We'll get into which types of therapy, which are still very prevalent. And then 60% at 3 months, and then 30% at 6 months. But there is a group of folks that continue to persist, and those are the key cases. So if we look at this, paclitaxel and oxaliplatin, these two, the taxanes and the platins, can cause either acute neuropathy right after chemotherapy infusion or after cumulative dosing. And you'll notice that this last point, it says there's an intensification of symptoms after stopping chemotherapy. And there's even a term for it. It's called coasting. There will be a number of different chemo doses, and then subsequent to stopping therapy, there'll be a persistence or resurgence of the pain, or even a beginning of the pain where you didn't notice it in the first few doses of chemo. And then, of course, it can persist for months, as we talked about, or it can persist for years, even after the cessation of treatment. Typical considerations are stocking glove distribution, numbness, tingling, altered touch sensation, impaired vibration sense. Paresthesias, which are abnormal sensations, painful sensations. Dysesthesias are what we call them. Allodynia, or pain just to touch, where touch normally wouldn't cause pain. And hyperalgesia, where you have almost a sense where you can have heightened, where if we gave pressure, we would expect discomfort, but we have heightened pain to stimuli that we normally wouldn't expect to have that type of response. Of course, there's also this alteration in warm and cool temperatures, and quality of life is disrupted with this. We have a loss of that extrasensory quality in life. We have our sight, our smell, our taste, and touch and feel that are all important to quality of life, and loss of that just degrades our quality. Distal weakness, eventually, when we kind of have the influence of motor innervation, impaired movements. And folks that have difficulty with proprioception have more likelihood of falling. And kind of noticed that in chemotherapy-induced peripheral neuropathy, if we focus on those individuals and we look at falls later in life, there's some correlations. So of course that can lead to disability and concerns like this. Now, lastly, peripheral neuropathy, we're talking about distal peripheral neuropathy sensory considerations, but there can be injury to the nice little transistors along the posterior aspect of the spine, which are our sympathetic trunk chain ganglia, which are all transistors related to our blood pressure, our heart rate, autonomic nervous system. And so as we start to injure those particular nerves, we have changes in the things they regulate, like blood pressure, constipation, urinary function, etc. So what studies can we use to kind of look and characterize this? And diabetic neuropathy, which is something that we're more familiar with, has usually been termed kind of a mixed neuropathy. And there's small fibers injured in diabetic neuropathy. Having that sugary blood where our blood vessels are floating through like Krispy Kreme donuts, where there's a lot of little frosting on them, and we get a hemoglobin A1C and we go, whoa, that's high. You're in tough shape with bad diabetes. That sugar, that kind of glycosylated sugary kind of blood has a relationship to injuring the peripheral component of the nerve. Not only that, an inflammatory immune relationship at the periphery of the nerve, at that important interface. Chemotherapy does so in a different way, but it has not so much of a mixed injury, but more of a sensory motor injury. And we know that neuropathy tends to focus on that objective sensory or motor requirement. The idea that motor, in terms of function, and sensory in terms of sense, are injured. But inflammation or pain that's accompanied is the neuritis part. So, like, for example, the typical terminology, just to kind of give by way of background, um, is sciatica, right? It's a form of nerve injury, usually by a disc extrusion pushing on a nerve, but we call it radiculopathy when there's motor or sensory discrepancies. I can't feel, I have a change in I have foot drop, but you can have foot drop and can't feel the leg and not necessarily have pain, meaning you might have motor changes or sensory changes, but not have pain. Radiculitis is the inflammatory component that we've given logic type compartments to say you have radiculitis or neuritis, inflammation, plus neuropathy or radiculopathy. They're both used simultaneously, and it's the idea that opathy suggests motor or sensory considerations are being injured, but exclusive or not mutually exclusive from the idea that you can have pain, which is the itis part. So both forms of neuropathy, though, are accompanied by pain, both diabetic and chemotherapy. And I think there's lots of similarities between the two. So here's where I'm going to kind of I'm going to submit this to the Senate floor to you and yield back eventually the rest of my time and see what you think. The idea is that if there's a parallel between diabetic neuropathy and chemotherapy-induced neuropathy, if there's parallels, there will be a parallel in some of the treatment. And so we'll kind of tuck that away as we kind of walk through these slides. So what are some of the risk factors? Well, age, of course, the older we are as we mature, like a fine Bordeaux over time. Yes, there's resiliency in our mind and our ability to think, our ability to maturely come up with really good decisions, hopefully. But there's other things. Our body's been around a bit longer. We've absorbed many hits, if you will. So age kind of doesn't portend the best when we look at this, when we're hit with chemotherapy, for example. If you already had a small fiber neuropathy, or you had diabetic neuropathy, and now you go in and you're unfortunately diagnosed with cancer, and you're going to have chemotherapy, that can actually compound things. History of smoking, because we know that high carbon dioxide level, CO2, makes the blood vessels constrict and decrease in size, and there's decreased blood flow to these small intricate structures that are almost like on a small drip system, like the juniper trees out in the front parking lot. They're getting very little blood supply, and it's critical, and carbon dioxide can alter that. Kidney function, which actually changes the actual clearance of some of the medications, and then cumulative dosing of chemotherapy agents, compounding things. And then, of course, the association of single nucleotide polymorphisms, which are just basically changes to our genes that suggest there could be some sodium channel changes. Now, when I say sodium channel changes, that's a mouthful, but the idea that I want you to hold on to not only the fact that diabetic neuropathy and chemotherapy may have a paradigm or relationship, but that sodium channels and the recent discoveries in the last 20 years really are going to relate to a game-changing effect for the next 20 years. And that there are many labs across the country riding the crest of the wave that's going to pretty much change the face of pain management. So we'll come back to that. So what types of chemos are out there? And I'm not to belabor this too much, are platinum-based drugs. That's our cisplatins, for example. Taxanes are the paclitaxels used in breast cancer, for example, which are microtubule disruptors. Oxalibepiline, thalidomide, vinca alkaloids, bortezomib. I won't try to go into too much detail with all of them. I'm going to try to suggest that they all have very much some similarities in how they influence chemotherapy-induced neuropathy. So this sums it up pretty much. these are chemotherapeutic targets. They are not, as each agent, they're specific, but the constellation of mechanisms that they use kind of portend the risk when it comes to neuropathy. So microtubule disruption, oxidative stress, injury to the mitochondria, damage to the fatty layer over the nerve, of course, which you can kind of imagine that would cause injury, and that's our kind of insulation to the nerve. DNA damage are all key in damaging or developing neuropathy. Now, here's one that's kind of interesting. The idea that chemotherapy somehow alters the immune system, of course, injures the nerve, but that there's some relationship between nerves and cancer itself. That actually the progression of cancer isn't just about small bits of cancer traveling on the blood highway, but that the immune system and the neurologic nervous system is involved in progression of cancer. And that's a newer kind of philosophy, but suggested in many, many reports as we look in the last decade. This is just a cartoon talking about activation of the immune system, mitochondrial injury. This is how chemotherapy is largely addressed with all these drugs. And I placed each one of the drugs, the types of chemotherapy, shows that where it's actually making its lesion, its injury, or microtubules, vincristine and paclitaxel, for example. It's been said that cisplatin, which is commonly used for big solid tumors like colorectal disease, small cell lung cancer, testicular cancer, and the like, so larger solid tumors, if you look at the top drugs in the world, like that have given people life, have allowed people to beat cancer, cisplatin, I mean, we're talking about across the developing world, across the globe, cisplatin is one of those top all-stars. That said, it can actually cause a lot of injury to peripheral nerves. So the oxalate metabolite accounts for some of this cold-induced neuropathy that patients will describe as having this cold sense, a presenting symptom to oxaliplatin. And that transporters, and here's what's really odd, and this is another point to just kind of hold on to, besides diabetic and chemotherapy-induced neuropathy, sodium channels, and then the idea that our chemotherapy agents somehow allow for accumulation of chemo, the medication, in the dorsal root ganglia. These are these dorsal root little onion bulbs that sit in the foramen of our spine, in the neuraxis, before the nerve emanates outside of the spinal cord, leaves the canal and into the periphery. These little onion bulbs that sit there as the dorsal root ganglion act as important transistors. And they somehow have a genetic predisposition to increase absorption of chemotherapy into those dorsal root. Altered expression of TRPV1 receptors on the dorsal root ganglion are also key. TRPV1 receptors are important as they are the receptor that's involved with capsaicin. This is another brave new world with pain medicine targets. They happen to be on the dorsal root ganglion that absorbs a lot of the chemotherapy. So TRPV1 is why it's part of the same family of receptors that are cinnamaldehyde receptors. These are receptors that when you see a commercial and someone takes a bite of gum and the next thing you know, they're putting on a parka and it's like that wintry fresh. It's these types of receptors that provoke cooling, that sensation, or lack thereof, or heat, like peppermint. And they're also present on the dorsal root ganglia. Now, I'll give these slides to you, and you can certainly have them to look at. These are just largely to have a little bit of an overdose on understanding that there's lots of injury with platinum-based drugs and how that injury with cisplatin would take place. What I would say is if you follow this down the line, you'll see that if you give cisplatin, and if I already kind of mentioned that the dorsal root ganglion preferentially absorbs or puts transporters out to the surface and absorbs cisplatin, that there's more proclivity for axon degeneration, cell death, atrophy or loss of the dorsal root ganglion cells themselves, or hyperexcitability, and this neuroinflammation kind of cascade, an interface, almost like a wave surrounding the dorsal root with neuroinflammatory kind of cascade of cytokines or molecules that are involved in the inflammatory process. So we see kind of these inflammatory mediators. Glial cells that live outside are trying to get activated, and we see disruption of this kind of excitability on the surface of the neuron, all in the setting of chemotherapy. And these are some typical ion channels that are disrupted, with in particular the sodium channel. More of the same when we look at paclitaxel, docetaxel, these all accumulate in the DRG, same theme. There's a transporter. And vincristine when it's utilized for leukemia. So these are more kind of also, you'll see slight nuances and differences with the taxanes, but largely neuroinflammation again, altered excitability. So thalidomide, as I was mentioning earlier, this is a drug used for morning sickness, and this medication, it turns out that the limb bud abnormalities when young babies were born without their arms or legs, that this particular drug, although thought to be a good morning sickness drug, was obviously pulled from the market. It turned out to be a vascular endothelial growth factor inhibitor. It actually stopped the development in some way of new blood vessels. But what's even more interesting is that that was a drug that then transitioned to its use and became an all-star in cancer care and became a drug used for multiple myeloma. Now, multiple myeloma is a cancer of plasma B cells, where these plasma cells in the bone marrow reproduce antibodies. And antibodies are produced, because all cancer is, right, is the reproduction of a particular cell line that's gone haywire. Well, that increased amount of antibodies can lead to strokes, heart attacks, even injury to the kidney. And so thalidomide has been an all-star in the setting of multiple myeloma. Now, it's an older drug, but now there are many other drugs like it, Velcade and others, that work in similar fashion. And they all pretend some risk to chemotherapy-induced neuropathy. So I mentioned thalidomide. So I'm going to stop here for a moment, and I'm going to mention a couple points. Now at this point, we kind of have a framework that there's many different chemotherapeutic agents. All of these therapeutic agents are used to kill cancer, reduce its progression, change cells from actually reproducing and dividing frequently. But at the same time, there's some fallout, there's some risks. And the risks that we didn't quite appreciate was that a lot of the chemotherapeutic agents are absorbed almost preferentially into the dorsal root ganglia of our spine. There's been many kind of thoughts, kind of Darwinian thoughts. Well, why would that be? Why is it that our dorsal root ganglion somehow preferentially absorbs chemotherapy? Is it somehow a glutton for punishment? Is what's wrong with this DRG? Why? Well, it's thought that evolutionarily, the blood flow around the DRG, it's wrapped with a little network of almost like a fishnet stocking of vasculature around it. And if you think of what it's protecting centrally, is the spinal cord. Our main central computer is being protected by these outside transistors that are sampling blood, in some way evolutionarily protecting the central cord in the brain from toxic agents, almost in effect acting as sentinels or guardians, if you will, of the central nervous system. Of course, it doesn't help us any. I mean, in the setting of modernity, here we are now. But the reality is that's most likely some relationship of what the DRG served as evolutionarily. Hence, this intense and robust vasculature around this little teeny onion bulb that serves as an incredible transistor to incoming information into the DRG, to the cord, to the brain. Now, curative preventive treatments for chemotherapy-induced neuropathy. I will tell you that the bulk of these treatments on here have all been nixed, meaning off the chart by the American Society of Clinical Oncology. They've looked at them and they said there really isn't great data for vitamin E, although it had its heyday. And then there's some folks that come back to nutrition in the nutrition world and say vitamin E is a great thing. Glutamine, alpha lipoic acid, glutathione, N-acetylcysteine, acetylcarnitine, calcium, and magnesium have all been looked at with very low benefit for preventative aspects to chemotherapy-induced peripheral neuropathy. Current treatments, I'm going to mention here that pretty much amifostine, carbamazepine is a sodium channel blocker. This was used. These are all basically anti-seizure drugs, right? Because if we think about a seizure in the brain, that's like a tempest storm, a hurricane of uncharacteristic electrical activity. It's like the frequency and the characteristic frequency and amplitude of firing for neurons in the brain is going haywire in this tempest storm. And so anti-seizure drugs were trying to quiet that tempest storm by altering electrical activity, by decreasing ion transport of charge. Well, many of the drugs, like for example, gabapentin, couldn't stop a seizure to save its life, right? So that went back to the boardroom. And of course, when they were in the boardroom, they said, Johnson, I can't believe it, you're a genius. The peripheral nerve injury acts like a tempest storm, but not in the brain, in the periphery. So we have a seizure going on in our feet. So they found a role for gabapentin in the periphery. And gabapentin is a calcium channel blocker, alpha-2 delta calcium channel blocker, with a very good history, typically for nerve pain, although not the best when it comes to chemotherapy-induced neuropathy. It's a good drug, but not the best drug. Lamictal, etanercept, pregabalin is the cousin of gabapentin. And gabapentin has a great track record in the sense that it was a blockbuster drug, right? So the number needed to treat for typical nerve pain, we'll talk about diabetes, for example, was about 3.5 individuals. There isn't a half an individual, so let's just say 3. So number of individuals before you'd see treatment effect was around 3. The number of individuals before you'd see harm was about 26, which is what makes it a blockbuster drug, meaning its risk profile is super low. And what would be the harm with gabapentin? It'd be things like abnormal thoughts, potential mood disorder, swelling of the ankles, sleepiness, sedation. So it turned out that gabapentin was a good risk to take. Pregabalin or Lyrica is the other drug that's great for nerve pain, but not the best. Lyrica is the cousin to gabapentin. It's the more potent version. And it too is an alpha-2 delta calcium channel blocker. Amitriptyline, nortriptyline, all these drugs were tricyclic antidepressants, which I'll talk about briefly in the context of this drug, duloxetine. Amitriptyline and nortriptyline as tricyclic antidepressants are, for lack of a better term, promiscuous drugs from the 70s. These drugs bind to many receptors. They love at different areas of the body. However, they have 2 components which are key. They block sodium channels and they have some relationship to serotonin. They're the most commonly studied because they've been around for a while. And they have a good track record or history in diabetic neuropathy. But in chemotherapy-induced neuropathy, less so. Which brings me to the last one that we can talk about in the interest of time is duloxetine. Duloxetine, or Cymbalta, is actually in the antidepressant class. And as an antidepressant, you'd think, well, what does that actually, how does that work for nerve pain? It turns out that if you are walking along the carpet and you step on a tack, pain shoots up through your foot, crosses over your spinal cord, goes up from the cord to the brain, and you quickly get that zinger and take your foot off the tack, and your brain starts to process you stepped on a tack or a Lego. I have young kids at home, so Legos are strewn about the floor like landmines. And if the lights are off in the middle of the night and you step on one, good luck. And as that pain shoots up into the brain then starts to attach relevance. Oh, you start to remember, what was that? You can't see it. It's dark. I remember I had a feeling like that with a nail when I was running across a dock in Tahoe when I was a young kid. Maybe. But then you look down, you realize it's a Lego, and there's a difference in how the brain perceives it. So pain comes up through the body on the 405 Interstate 5 freeway which is called the spine brain tract, the spinothalamic tract. Just as quickly as it comes in, the brain perceives it, processes it, and then as we look down and we notice it's just a Lego, you're not at risk, it attenuates the brain incoming pain. All of our bodies have the ability to attenuate incoming pain. It's an incredible ability that's harnessed by all cultures, whether it's the Shaolin priest, the Buddhist monk. It's the ability to attenuate incoming pain with a brain spine tract. So we talked about the spinothalamic tract or the spine brain tract bringing pain in. The brain spine tract or the corticospinal tract, it runs off high octane monoamines, that is serotonin and norepinephrine. And if serotonin and norepinephrine can be increased in the right amounts in certain areas of the brain, that allows us to attenuate or harness our own ability to decrease the volume on incoming pain, which is why duloxetine won FDA approval, not just for nerve pain, but for musculoskeletal pain as well. So if they were in the boardroom, in this case, in that company going, my goodness, Richard, you're a genius. We can take care of all pain with one drug. And I know what you're thinking. It's like I have a top hat and a cane, and this cures all that ails you, one medication. But the reality is it's influencing the ability to attenuate incoming pain. So these say 2014, the 2020 guidelines are the same. First line, duloxetine, limited efficacy for everything that I mentioned. And now I'm going to kind of mention a little bit about, before I'm going to go back to this really quick, because I know we want to have time for questions, and then we're going to talk about spinal cord stimulation. But I think this is a good moment to just chat about pie in the sky and what I meant by dorsal root ganglion, diabetes, sodium channels, and UC Davis. And what does it mean in terms of new therapies? It turns out that about in 1996, the Human Genome Project was completed, and a lot of people said, okay, what do we do with all that? Well, it sat there for another 4 years, all the genes kind of deciphered, the Rosetta of all stones kind of sitting there. In 2004, there was an interesting group of researchers. They were traveling Pakistan. Now, many of us have ran into individuals that if we have a certain sense that you notice they don't have, like for example, the folks unfortunate that are blind or can't hear, or even more rare that can't smell, anosmia, or can't taste. But it's even more rare to run into somebody who's never felt pain, but they exist. And hereditary insensitivity to pain is one of the unique phenomenons that allowed probably the next chapter in treating nerve pain to have some positive results, which is in the next few years. In 2004, there was a group of researchers traveling Pakistan from the UK. So they met a young street performer who was walking on hot coals. He was about 14 years old. And they said, hello, young chap, looks like you can walk on those coals for days. And he's like, yes, I can do it all day long if I needed to, but my feet would certainly pay the price. They asked him further and they said, it sounds like this is a real incredible. You're able to do this. Are you the only one? No, I'm not the only one. My father, his father's father, my uncle, and there was a phylogenetic tree of individuals that they were able to research. It turns out that those folks had a missense mutation in a specific type of sodium channel. And for the longest time, we understood sodium channels to be two categories: tetrodotoxin sensitive, which is the poison venom in a pufferfish that we would use to sprinkle on sodium channels and turn one off and turn one on, or be sensitive or insensitive, that we only had two types. But actually turns out we have more than 12 types of sodium channels. And that they found that sodium channels that are specifically relegated to C fibers, pain fibers, the fibers that carry pain sensation. So the sodium channel is called sodium channel 1.7, and it pairs with sodium channel 1.8. Since that moment in 2004, and the last 16 to 17 years leading up from that discovery, there has been a race It's been a quiet one, but a race led by many multinational pharmacy organizations, from Vertex to, you name it, Eli Lilly to others, and to homegrown universities like UC Davis, who have developed labs to study sodium channel 1.7 as a new target for treatment paradigms for nerve pain. So I mentioned that as to put on burner number one, slow simmer, as we understand all these concerns with nerve injury and using chemotherapy as a paradigm. We can then now say, well, maybe that drug isn't available to us now, and maybe there's a chance that we don't need a drug. So the use of the spinal cord stimulator is a strategy to treat nerve pain in the feet. This is much like a pacemaker that we put in the body, and as a glorified charlatan, I distract the brain from pain. I mentioned earlier that duloxetine attenuates our ability to actually bring in pain. The spinal cord stimulator has the ability in many ways to distract the brain from pain. We can get into that. Some of the pros of using it is that you may have progressive chemotherapy, radiation, or surgery. Folks may be immunocompromised, and it may be a good strategy if you don't want to give other medications. It may be a poor strategy if they're too debilitated to be able to have the device. MRIs used to be one of the problems, meaning we need an MRI to get more understanding of your disease as you have it, and the device wouldn't be compatible, but now they are. So that's a moot point. High frequency stimulation, burst stimulation, are all different forms, and that's just two. There are many software strategies, meaning Silicon Valley is implanted into a patient's back with nerve whispering to distract the brain from pain. Now, high frequency stimulation has been now found to alter sodium channels at the level of the dorsal root ganglion. So here we have an understanding that the DRG, the dorsal root ganglion, what we had talked about before, as being an important transistor that absorbs a lot of chemo, that tends to disrupt sodium channels, that now this new high frequency stimulation has some type of perceptible shift or change at the level of the DRG, and it's based on sodium channels. So that leads to the latest, and then we'll be able to end. If the dorsal root ganglion, this little onion bulb in our cord, is involved in so much of this, wouldn't it be interesting if we could just put the electrode and just kind of caress the dorsal root ganglion with the electrode and stimulate it with all of the software implications I mentioned? That device actually came out as of just over 2 years ago, and we offer that at UC Davis. That's called dorsal root ganglion stimulation. And this portends probably the next stage in non-medication strategies to treating pain in the feet from chemotherapy-induced injury. So more coverage of the foot, less unwanted paresthesias, less migration of the electrode. It doesn't move around as much, meaning the technical challenges. However, it's not MRI compatible yet. So I hope this helps. There was kind of a strategy that, yeah, we're living longer with cancer. Cancer is now, in many ways, considered a chronic disease as we look at survivorship. Chemotherapy has many shared mechanisms that induce injury, and it's a common thing. So it'd be nice to marry these strategies and this type of pain care to cancer care. And more on that later in another talk, perhaps. The finances don't add up exactly yet. We think that there's unique involvement of the dorsal root ganglion because maybe there's an evolutionary principle associated with it. Treatments are limited in terms of oral medications, with the top drug being duloxetine by attenuating incoming pain. As an antidepressant, increasing serotonin and norepinephrine, it decreases the volume on incoming pain. And spinal cord stimulation may portend a very unique strategy that's not a drug for treating persistent, intractable chemotherapy-induced neuropathy. I hope that helps give a quick little run through of some unique topics. Go ahead and end the show here. I'm sorry, Daryl. You might be muted. Let's see, maybe I can. Okay, so some questions I see here in the question chat. It says, can diet help with peripheral neuropathy and progression? I get different opinions. How does one isolate a psychosomatic contribution when one is diagnosed with idiopathic peripheral neuropathy? And any comment on utilizing alternative pain management strategies like cannabis? Great points. Let's start with the last one. So, because that's the one that you know. So I would tell you that the story of marijuana in general in the United States has a storied history, and the Controlled Substances Act still to this day federally, which is where we get our drug enforcement, the DEA license to prescribe controlled substances, suggests that marijuana has no medicinal value. It turns out that there's about 8,000 publications in PubMed on the medicinal value associated with molecules somehow associated with the plant, indigo sativa, and of what we now know as marijuana, right? It turns out that if you can look at certain types of cannabinoids, cannabinoids are not the THCV or THC cannabinoid that is involved in getting people high, but CBD products have an incredible ability to treat pain. But there's so many of them, and there's no regulation on dose or standardization of how to get at them, that many patients will buy CBD for $40 at Rayleigh's or at another location at a dispensary, and they won't have good results. It turns out that CBDA specifically is involved in treating nerve pain, and high dose CBDA can be incredibly helpful. There is a group in Marin County called Circle Labs that focuses on just CBDA alone. And I know this sounds like some kind of an interesting winery or vineyard, but it's from a single block stock of plants in Oregon that have been genetically positioned to grow and produce high concentrations of CBDA. It turns out that CBDA is also tumoricidal. So a whole nother avenue, and it's involved in the immune system, tumoricidal, and involved in that neuroinflammatory interface. So yes, CBDA, certainly helpful. Cannabis is helpful, and even more focused is the cannabinoid, and Circle Labs makes it. How does one isolate, identify psychosomatic contribution when one diagnosed with idiopathic peripheral neuropathy? That's a hard one, because when you have pain coming in through the hands and feet, how can you not be, how can your mood not be influenced? About 60% of chronic pain patients have depression or can be depressed. And it's to validate them. It's a very severe consideration. But sometimes that contribution can be mitigated by cognitive behavioral strategies or treating the pain in an effective way in conjunction with cognitive behavioral strategies. Reframing. These are ways in which we can use our mind to help reframe our current position with what we're afflicted with. And for some, it's a great strategy. So part of our pain division, we actually have a pain coach or an excellent psychologist who runs our behavioral component to the program. And almost every patient sees him as well, because it's an indelible relationship. very closely related. Can diet help with peripheral nerve pain and progression? I get very different opinions. I believe it can. I believe that we are what we eat, and yes, there can be some strategies. There isn't a formal pain diet. You probably saw throughout the slides the idea that there's some kind of inflammatory interface, neuroinflammatory interface. I use that word a lot. So reducing inflammation in many ways can be helpful. And there are many diets that demonstrate success in reducing inflammation. Probably if I had to put my finger on one, despite the fact that no society in pain management supports a good diet, like for example, a diet like International Association for the Study of Pain, American Pain Society, none of those organizations did, or American Academy of Pain Medicine. The Mediterranean diet with modest amounts of protein, only water, tea, green leafy vegetables, and then and protein in the form of fish and chicken, and cutting out lots of dairy, which dairy and casein has been known to be pro-inflammatory, portends some benefit for many different types of inflammatory interface type conditions, whether it be bowel inflammation or peripheral nerve inflammation. My neuropathy is idiopathic. I don't have diabetes and have not been treated for cancer. And I also have fibromyalgia. I'm 55 and no one in my family has it. Thoughts? Well, it's true. There are things that we just don't know, right? That's hence that word idiopathic underlined and italicized and bolded. It's possible that if we're able to do EMG nerve conduction studies or learn a little bit, if we can, if it's a small neuropathy, we might not be able to, but if we're able to characterize it, then we may be able to get approved some of these other treatments like spinal cord stimulation. So it doesn't mean that you have to have cancer. It doesn't mean that you have to have diabetes. CBD products, to be quite frank, I mean, I would tell you, I think that the risk profile is very low and the benefit is very high. In addition, duloxetine, like I mentioned, attenuates incoming pain, whether it be musculoskeletal or from the nerve at the level of the brain. And so under the direction of a doctor, it can be very helpful. Lastly, so the consideration for ointments, there are a lot of different ointments. We do a lot of compounded therapies. Those therapies actually look at creating creams that are customized, and they have a vehicle called lipoderm, which drives medications through the dermis into the tissues. And we can place high dose ketamine, a great nerve pain medication, into a cream where it's not absorbed systemically. We can put CBD products into the cream as well as high dose local anesthetics that can't be purchased over the counter or by prescription. You have to do this by a compounded agent where we make the cream ready to order. And that's something we do routinely at the pain division. I think I
Can you see the very bottom one?
Any experience with Scrambler? Okay. And how about low frequency electroacupuncture? Got that. Got it. Scrambler. Do we have just 2 more minutes or 3 more minutes? Or
we've got as much time as you really want.
Oh, okay. I'll mention this to be helpful. So the way that the spinal cord stimulator works and the way that Scrambler works and the way that these devices, so let me just give a kind of a 1 minute, 30 seconds of background. As pain comes into the spinal cord and then goes up to the brain, pain and sensation, touch, travel on 2 different roads. Pain travels on service roads, small wispy copper wires that don't have insulation on them and carry the information very slowly. Sensation travels on big fat fiber optic cables that can transmit lots of information quickly. And that comes into the cord. I went to give a talk for UC Davis on pain, and I was lucky enough to do it. It was in Japan. And there was a presentation, a cultural presentation on pain. And it showed that almost every individual, they bumped their elbow and they would rub it. It would be like, "Ay, shinpai, irimasen, to, arigato," and they rub it. In Spanish, they would go, "Ay, me duele, qué bárbaro," and they would rub it. Every culture, and they showed these pictures. Long story short, what does rubbing have to do with anything? Rubbing has everything to do with everything in the sense that as pain comes in to the spinal cord, when we rub our periphery, we rub it, we actually enact the switchboard in the spinal cord and the switchboard operator in the spinal cord. The switchboard lights up with rubbing sensation. It comes into the cord and lights up the switchboard. So all those phone calls of rubbing go up to the brain to be perceived. Pain from the initial injury, bumping your elbow, is still coming in, but it's coming in slowly and relegated to a small section of the switchboard at the very bottom. So what ends up happening is the brain becomes distracted by rubbing. Rubbing is the primary input, and pain less so. The spinal cord stimulator does the same, harnessing this ability to overwhelm the brain with a different sensation and distract it from pain. Hence the scrambler, hence the spinal cord stimulator. And the name of the theory that allows us to do this, the fundamental theory, is called the gate control theory for pain. So that's the scrambler. Is it successful? It can be, because it's like a TENS unit, transelectrical nerve stimulator unit. It puts these considerations on the body, but it's unclear how sustainable it is, because as soon as you take it off, it's unclear how long it will last. And I know that there are varying reports when it comes to the scrambler. Think about the spinal cord stimulator. That's an implanted device where you have a remote control. It's a little weird, Star Trek-like, but that's so yeah. How about low frequency electroacupuncture? Totally different strategy. That goes back to the ages, right? Because acupuncture functions at the I'm just a humble Birkenstock wearing pain doc, right? But the idea that allopathic medicine is relatively new with Hippocrates, but even before Hippocrates, that there was an idea that the body has meridians and that this acupuncture influences our chi. And electroacupuncture can be helpful at influencing a whole different construct of how the body functions. I think that there's something to it. Of course, when President Nixon came back and he said, "Wow, there's this thing called acupuncture. You guys are missing the boat." And now we're at the forefront where acupuncture is applied in about 76 different cancer centers, all NCI accredited across the country. Acupuncture is a great strategy for fertility, for nausea, for nerve pain, and for pain in general. And Medicare just approved acupuncture as part of CMS guidelines for low back pain, January. So to tell you that acupuncture has found its time is here. And could acupuncture be helpful for nerve pain? Yeah. Did I miss one? I'm in Southern California. How do I order lipoderm ointment that contains high-dose ketamine? So lipoderm ointment, you'd have to go to a pain doctor or another physician. Usually it's a pain specialist. Ask if they have compounded, if they do compounded therapies. The type of ointment would include ketamine, include lidocaine. Sometimes we include baclofen. Baclofen's a muscle relaxant, but good nerve medication in addition to lidocaine, plus the ketamine. And the concentrations of each ingredient. This is compounded therapies are not covered by insurance. They used to be in 2015. Medicare stopped and then everybody else fell in line. So it costs around $60 to $80 for a tube of a compounded cream like this. But it would be under the prescription of a physician. And for example, lidocaine cream or ointment is about 4%. You can make this 10% lidocaine or tetracaine. It can be very potent to numb. And that's usually if you're feeling burning pain, it can be helpful. And then of course, ketamine, which is a whole other talk. I could talk about ketamine and just neuropathy and nerve pain for ketamine. We have an infusion protocol where we give IV ketamine for chemotherapy induced neuropathy at the cancer center. So ketamine in a cream can be helpful. Of course, we offer IV because we think it's more helpful. How does DCS, dorsal column stimulation, hold up over time? Complications, great question. So the data shows that we'll have patients, most data goes out 2 to 3 years, which is pretty good for medicine. They don't really follow people out a lot in terms of 10-year data. But we do, I can tell you anecdotally at UC Davis that we do place a lot of spinal cord stimulation devices. And it's not uncommon that we're changing the batteries, which have a 10-year life expectancy, meaning the electrodes are in good position, but then the battery needs to be changed because there's just new technology. Now all the batteries or the generators all have updatable software. You can actually update by Wi-Fi your device. I know it sounds crazy that you have a device implanted and you can update it, but it'll be updated with all new programs, and the contacts on the device inside the body and the spinal cord will have new ability to communicate in different ways, which will help distract the brain further. So that's another strategy. I think I got them all.
I think you did. Well, I want to really thank you very much for all the excellent information and really putting things into perspective. It was an excellent talk, and I think we all learned a lot. And
Okay.
so thank you very much.
My pleasure. Okay. Thanks again, Daryl.
Thank you.
All right.
Have a good day.
You too. Take care.
All right. Thanks. Bye-bye.
Bye-bye.